Any last questions, or shall we just move on? Thank you. Excellent. Okay, so I'm really pleased to introduce our second speaker in this session. Professor Guy Goodwin is Chief Medical Officer for Compass Pathways, who's been working to remedicalise the psychedelic experience for use in psychiatry. He is Emeritus Professor of Psychiatry and NIHR Emeritus Senior Investigator of the Year at the University of Oxford. His research interests are the treatment of mood disorder and investigation of new treatments, including new drugs and new technologies. Professor Goodwin is a fellow of the American College of Neuropsychopharmacology and has previously held the position of President of the British Association of Psychopharmacology and the European College of Neuropsychopharmacology. He's also Senior Investigator of the Faculty of UK NIHR. And I'm delighted to welcome Prof. Goodwin.
Thank you. Thanks very much. So I'm here to talk about one trial, and that's I'm going to sometimes refer to as 001 because that's our jargon expression for it. But it's really about the use of psilocybin in a crystalline form for treating treatment-resistant depression. So I started off as the principal investigator for this study, and therefore I was kind of independent and in the academic sphere. And I subsequently joined up, so I'm employed by Compass Pathways with all the conflicts of interest that implies. Just a note to say that I have to say that I may be making forward-looking statements, and that means if you're planning to invest in Compass Pathways, you should look more carefully at their SEC submissions and not listen to me. So I'm obliged to say that. So what I'm going to cover a little bit is psilocybin and the psychedelic experience, look a little bit about evidence at healthy volunteer studies, talk about the clinical trial background so far, and then look at treatment-resistant depression as our test case for remedicalizing the psychedelic experience. The start of medical use of these kinds of drugs goes back to 1943. Albert Hofmann was a scientist employed by Sandoz. He was synthesized LSD, and that was in 1938. It was an ergot extract, and he had a sort of strange presentiment that this was an interesting drug. 5 years later, he turned that presentiment into a further interest by accidentally absorbing some of it and having a sort of experience. So he decided to properly dose himself, as he thought, with a low dose of LSD, 250 micrograms. And he took that as a single slug one morning. And that's now referred to as bicycle day, because, of course, he was the first person to experience a full-blown psychedelic experience at the hands of LSD. And he tried to cycle home, which was an interesting experience for him. He developed a very severe paranoid feelings about what was going on. He was frightened to death. He absolutely thought he was going mad. But subsequently, in the course of the afternoon, things settled down, and he then became fascinated by the effect he found, and he followed that up in a lifetime of investigation. And he, in fact, was the first person to isolate psilocybin, which we'll talk about in more detail. The other interesting thing, I guess, about Hofmann is that he was always regarded this as being something that was related to consciousness on the one hand, so he emphasized its sort of philosophical interest. And secondly, he had sort of inadvertently proved that transmission in the brain was chemical. Because up to that point, certainly till about 1947, 48, that was still contested, and people thought transmission at synapses was electrical. And this was really the first amazing evidence that it had to be chemical, because the doses were so small, the effects were so dramatic. So he was an important finding. So we now know that, I'm jumping over lots of stuff because this was a big stimulus to basic science as well as to a certain amount of clinical research in the 1950s. Early days for brain research, of course, but nevertheless, it was pushed on dramatically by an interest in this class of psychedelic experience. I'm going to emphasize it's a psychedelic experience because it's also a drug effect, which is probably through 5-HT2A receptors predominantly. And the drugs that are implicated in that sort of action are just listed here. So you can see LSD, DMT, and you can see the LSD is the only absolutely synthetic version, but we are using a synthetic form of psilocybin, although it occurs, as I'm sure you're all aware from the papers, in mushrooms. And indeed, one of the places you can pick those mushrooms is Craig Lockett, where Royal Edinburgh Hospital used to be. It's a famously good place to find these mushrooms. So there you go. A little local knowledge for those of you who live in Edinburgh. 5-methoxy-DMT is extracted from toad venom. And the thing about DMT in a pure form and 5-methoxy-DMT means they're very short acting. So there's interest in these compounds because they're a sort of 15-minute experience, and these other drugs are much longer. LSD impractically so, because it can run for 12 hours. Psilocybin, sort of 6 to 8. I would distinguish this sort of experience from the dissociative experience that we get with NMDA receptor actions. With ketamine, S-ketamine, phenylcyclidine, and even nitrous oxide is thought to work through those receptors. Interesting in the treatment of depression, I don't really have time to do it justice, but it's part of an evolving excitement in the field that we've really started to get new ways of approaching difficult to treat diseases. Now, serotonin is on the left, LSD is in the middle, psilocybin is on the right, and you can see very clearly that there's a sort of one end of this molecule is very similar to serotonin, and it's even more similar if you've knocked out that phosphate group, and that's what happens in life. The psilocybin is cleaved to psilocin, and that's the active compound in the body. And as you can see, it then looks very like serotonin. So this is a serotonin effect, if you like. The actions predominant in this cortex, and in the cortex, you find a lot of 5-HT2A receptors. There's a certain amount of inequality in the distribution, but it's very much in visual systems and also association cortex. We think that most of the effects are mediated through pyramidal neurons, and the effects are very dramatic at a systems level, because you can obviously look at, either in animals or in man, changes in connectivity under the influence of the drug. And this can be sort of related to the fact that there's a very clear dose effect. So this is showing, sorry. So there's a very clear dose effect. These are PET studies that show you the intensity of the subjective experience on the vertical scale and the occupancy of the receptor, 5-HT2A receptors, on the lower scale. So what I want to emphasize to you is that we're dealing with a drug effect. So this is something that is precipitated by the drug, is related to the dose of the drug, and as you'll see, the effects that we see clinically are also related to the dose of the drug. Now, what it does is symbolized on this slide, and this is a sort of attractive explanation, which is in some ways too attractive. On the left, you can see in different colors, symbolically, the brain areas that are connected to each other at rest in the human brain. And there are different networks. The default mode network is one everyone heard about, but there are several others as well. And they represent the resting brain communicating with itself in a particular stereotyped way. And what you can see is that the different colored blobs communicate with each other, but they don't communicate across to different colors in normal conditions. What happens when you have a psychedelic experience is that you have this greater connectivity between these areas. And what patients describe is something very much, as it were, correlated with that, which is that their memories, their experiences are much more open to different sorts of interpretation, different sorts of perception, different sorts of relationship to one's identity. So all of these things are very like extremely vivid dreams. One knows that they are not real in the literal sense, but they are experienced as having significance, and they change the way people think about, very frequently, about memories and how they feel about themselves. We're treating with a drug, so does this drug have adverse effects? We started off with a healthy volunteer study, and this simply concentrates the mind on day 1 and shows you that most of the adverse effects, which are somewhat dose-related, this is 25, 10, and this is placebo, most of the effects are concentrated on day 1. Subsequent effects are at a pretty trivial level. So that this is effectively, from the drug perspective, this is a one and done kind of experience. We'll come on to other potential problems for patients, because this is healthy volunteers, but this is sort of helpful to set the context. Now, the history of how we went back to use these medicines really relies on studies in academia, and this is a sort of timeline that shows you several of them. The details are not terribly important because all these studies are too small ever to convince regulators to license these drugs for use in man. And this is a common problem that we have with academic studies, that they're great for papers, they get us grants, but do they actually change practice unless regulators say that you can have these drugs available for clinical use? And the answer usually is no. So what you've got here is initial stall study, and these are patients with cancer. So this existential distress, fancy word for the sort of anxiety and mood symptoms that patients with cancer have. And the details are not important, but essentially these studies gave us some comfort in the idea that this would be a treatment that reduces depression and anxiety symptoms very quickly. And that there was a reasonable control in these two studies, not fantastic. Then there was a movement on to look at treatment-resistant depression. This was David Nutten College and Robin Carhart-Harris in Imperial College in London. And then there was a further study from Johns Hopkins in major depression, which had a waiting list control. So all of these studies were suggesting that there was an effect, that there was a there, but in no ways were they conclusive. There was a final, the final thing is, where should one try and look for an efficacy signal in the treatment of patients with depression? This simply shows you that basically effective treatments are not very effective in depression. So antidepressants have a modest efficacy. At most, they get about 1/3 to 40% of patients well in remission with treatment. Of course, people argue about how different that is from placebo, but let's not go there particularly today. The next line treatments, people still fail at that stage, and you end up at 3rd line treatments with very low response rates and a rather wide smorgasbord as alternatives that people don't really know how to choose between, and they're shown on the far side as treatment-resistant depression. So it seemed to us logical in terms of developing a new treatment that rather than competing with an SSRI, you would want to go to this 3rd level of treatment where patients are already difficult to treat. Now, what is psilocybin therapy? Essentially, the key thing is it has to have a safety wrapper. It's a very misleading term that you'll have heard, which is psilocybin-assisted psychotherapy. I would insist that our trials are really not offering psychotherapy. We're offering a therapy support to prepare patients so they know what they're letting themselves in for, to explain the trial, to obtain informed consent, which is difficult in this area because you're consenting to something it's very hard to describe and the patient will not have experienced before. Then the day of the dosing and the single administration of the drug, the patient has to be supported. They're in a vulnerable state. A lot of nasty things could happen to them if they were simply left to their own devices, or if you had a corrupt therapist. So that's a day which is important to be careful, to safeguard. And then there's integration, which is just meeting up afterwards to find out how it was for the patient, to get some sense of their interpretation, give them an opportunity to talk about things in a structured way. The traditional underground psychotherapists of the West Coast of the US put a big store on this because it's their living. And they want this to be very, very important to the overall outcomes. We are really agnostic about that, but from the point of view of a clinical trial to prove a drug works, the less integration you have, the better. So our patients are only getting 2 sessions, one of which is largely an assessment session when they come back on day 1 after taking the drug. So that's what they're offered. The context, and this is something that goes back again historically to how this has been used by therapists who are working on the underground, is that the setting has to be right. And we think it's important that the room should be somewhat vanilla, but nevertheless nice, clean, cozy, quiet. And the patients come in, they put on eye shades, they put on headphones and listen to music. So they are immersed in an inward journey, if you like. They are not communicating much with the therapist. At most 10% of the time is the estimate with the higher doses. So essentially, we're looking at a drug effect supported by a therapist. So what was the trial? So this was a phase 2B clinical trial. So it was intended to fit with the FDA's ideas of preparedness for registration studies in phase 3. Patients had treatment-resistant depression, meant they had at least 2 and as many as 4 failures of treatment. They had to withdraw from any current medication, and that took a little time to be careful. It didn't prove to be terribly difficult. In fact, we worried about that in advance. These patients therefore spent 3 to 6 weeks in a run-up to the actual day on which they received the drug. In that time, they received 3 sessions of preparation, which I just described. So that was the run-in. On the day of the dosing, they were randomized to get 1 milligram, which we expected to have rather minimal effects, 10 milligrams, about which we were agnostic, and 25 milligrams, about which we were interested. I think from the discussion of clinical trial design earlier, you see we got away from the simple placebo-drug comparison, which is often rather unsatisfactory, to something that would be looking for a dose-response relationship because of that relationship between drug occupancy of the 5-HT2A receptor and dose. Patients were assessed for response using the MADRS rating scale. That was all done remotely. And this study was conducted during COVID. And thank goodness it was done always remotely. So there was no actual change in methodology when the COVID restrictions cut in. It also means there was no risk of bias from the sites or unblinding influencing how patients were rated. The pre-decided primary endpoint was at 3 weeks, and the order of comparisons we made was 25 to 1 milligram and 10 to 1 milligram. What you'll see is a 1-to-1-to-1 randomization follow-up for 12 weeks. So it was a successful study because it appeared in this journal. And as you can see, it was a cast of thousands who actually performed this, and we tried to acknowledge everybody who had really made meaningful contribution to the study. And it was an exciting moment for all these people when this was published, because it's a big deal to get into this journal. It's very nice, you know, my own vanity score went up very high, but the key thing really is that this is good for the field. This means you kind of get passing the highest test you can pass to say this is a legitimate clinical trial. Now, what was the trial? What did the trial show? Well, these are the outcomes. You can see, first of all three groups had a rapid fall in symptoms. So at day 2, you had a maximal effect, in fact. So this is before any integration takes place. So it very much argues for a drug effect. You can see that it's sustained out to 3 weeks with a very clear separation, 1 to 10 to 25. And the 25 to 1 comparison is statistically significant. If you like p-values, and we all like p-values, it was 0.001. The patients were continued in the study, but beyond 3 weeks, additional treatments were added because you can't keep the purity of your trial for very long when you've got a treatment-resistant population, many of whom are not responding. So from about 3 to 4 weeks on, you're getting contamination by additional treatments. But what you can show is that if we look at response rates, and this allows you comparison with other modalities, you can see very high rates of response at 25 milligrams, which tail off a bit over the 3 weeks, but come down to something like 37%. That compares very well with the very low response rates in STAR-D at this equivalent stage in the treatment pathway. And then finally, who sustains response? Well, about 20 to 25% of patients were continuing to show a sustained response at week 12 without any additional treatment. So this is 20% of a treatment-resistant population, a single treatment, still well at 12 weeks. Again, arguing against the idea that this is likely to be in any way related simply to placebo or to any other artifact. Adverse events, which have to be recorded in tedious detail in drug trials, but they're important. I think if I'd been asked, I wouldn't have been confident I knew what severely depressed patients would experience under this drug. It turns out to be pretty benign. And most of the complaints patients actually make are these physical symptoms, which are relatively common. And so people have to be prepared for these. And it's kind of the headache, the nausea, the euphoric mood, the fatigue. It sounds a bit like a heavy night out in Edinburgh to me. I mean, it's sort of got that quality to it, that people have had a hard day, as it were. And this is kind of the way they describe it. But it's not highly traumatic. Very few people have bad trips, to use the term. Anxiety is not particularly prominent in the symptoms that the patients express. Suicidal ideation in this group is always a big issue. And even though we had to, the drug effect only lasts for a day, we have to follow them forever to determine whether or not there's increased suicidality in the 3 groups. This was variable at baseline, as you can see in these top numbers. So this is a variable measure. The participants showing any worsening are shown in this second line of figures, and you can see it was somewhere between 9%, 15%, and it was less in the 1 milligram group. Now, I have no idea why that is true. I mean, that might be a signal that tells us we have to be very careful about disappointment in the patients who were treated and didn't respond. But for the moment, we just simply don't know. We need larger studies, which we will get in phase 3. So this is the development protocol for any trial. any treatment in medicine, you have to go phase 1 for safety and feasibility, phase 2 to demonstrate your sort of endpoint and preferred analysis plan, and then into phase 3. And we hope phase 3 is going to be conducted, at least in part, along either end of the M8. So what's it going to look like? The program will launch, the first of these trials will launch by the end of this year, the second next year. And the key things we wanted to do and to address were, first of all, to replicate the effect that we'd seen in the first study, in the phase 2b study, to also look at placebo, which the FDA insists that we do. So it has a safety baseline, so-called, which is fair. In other words, it's a null, it's what placebo does. And that study will be powered to detect an effect at 6 weeks. The second study will address whether or not a second dose is a good idea. So it will take 2 doses at 25, 2 at 10, 2 at 1, endpoint at 6 weeks again, and that will give us some idea whether, for example, a double dose of 10 milligrams is an advantage, because that would reduce the exposure to drug, or whether, in fact, double dose of 25 gives you extra benefits. We will see. That's why we do research. So I'll stop there. This is a quote from one of the participants in the Imperial trial. I think that from my own talking to patients, I think there is a genuine qualitative effect of this drug, quite apart from its effects on ratings. But that's something that it's never going to cut ice with regulators. But I think it will cut ice with the patients, the people who take it. Thank you very much.
Thank you very much.
Okay.
That was excellent. We'll move on to questions. Are there any questions online? Okay, go for it in the room then.
Hiya, I should declare I'm a psychologist. And when you had the circles up in the mechanism, it reminded me of EMDR therapy, how that works. I just wondered if like trauma was screened for, or if that is part of the hypothesis at all.
We've got a study looking at people with PTSD, just an exploratory study. We're basically we're not trying to look at comorbidities. So, you know, there's going to be a place for this approach for PTSD and for depressed patients with that comorbidity. The nature of these trials are artificial. I think there was a great slide earlier on saying that, you know, clinical trials were an experiment. That's what, unfortunately, they are. What we will have to do is to look at real world studies with more realistic patients who have these comorbidities, but not yet.
Yeah.
Okay, hi. Yeah.
Sorry, I'm sorry.
It's okay. I thought there was someone that can answer. Is there any possibility of something like that ever working with someone who has schizophrenia and depression?
I think there's every possibility to work on depression. I'm not sure that I would want to hold out much enthusiasm for schizophrenia as a syndrome, but certainly I think depression probably has common mechanisms, and I would expect this to be effective. LSD was used on patients in the 50s, or given to patients with schizophrenia, really at scale in some centers. And so there's a certain amount of safety information. It doesn't make people a lot worse, but it didn't actually make them a lot better either, to be honest. So,
Yeah, but it could work on the depression.
But the depressive, I don't think there's any reason why you would exclude in real practice patients with schizophrenia who had depression.
Hi there. I was wondering, I know that psychedelics have received a lot of kind of bad press and controversy in the past. And I was wondering, how do you find the openness of the scientific community and clinicians around you in terms of using this approach?
Well, I'll give you two answers to that. The first is that our publication in the New England Journal of Medicine was put alongside an editorial which basically said that these were dangerous drugs that should never be given to people, right? So there's still a part of the medical establishment, and a very important one, who don't like what we're doing, okay? I don't find a lot of opposition among psychiatrists. I find a lot of acceptance, particularly young psychiatrists, but actually old psychiatrists as well. Some of us remember the 60s, and, you know, it wasn't all bad. So I think to be honest, that the pushback has really not come from that. There have been quite good surveys also in the general population that suggest that there's pretty wide openness to trying this way of doing things. And I don't think from the way people recruited into the studies that there's any barrier for patients, because in fact, people running the studies have said unusually, actually, they get contacted all the time for people who want to come into the study. And those of you who run clinical trials, run the network, will know that that is not the normal experience of patient recruitment. So we'll see.
Hello. That was weird, hearing my voice. Thank you for the talk. I was wondering, kind of off the back of that question, are you finding, as you're going further with these studies, you're finding pushback from the regulatory bodies, or they're becoming more and more cooperative with this sort of stuff, just because you think about it in the UK, for instance, and psilocybin or magic mushrooms is still a class A, and you still have the culture around it, and you look at sort of previous stuff like Professor David Nutt, for instance, a few years ago.
Yeah.
Yeah,
I mean, if the definition of a class 1 drug is that it has no medical use. In a sense, if we demonstrate it has a medical use, then there's an automatic rescheduling. That's true for the United States. It's true here. So all we have to do is to get the scientific evidence right. I think we will be okay. I can't talk in detail about our conversations with the FDA because they wouldn't like that, and I understand why. But all I will say is that our phase 3 program was agreed in discussion with them. So they put no block on us doing these studies. There's been no unnecessary delay, but there's been no substantial delay. Communication is slow with these bodies, but they are not deliberately slowing things up to get in our way.
One more question. So I'm quite interested. You reported the raw within group change in the groups. My understanding is the sort of standardized within group change for placebo in treatment-resistant depression is one standard deviation. So people will move by a whole standard deviation just by taking.
Yeah.
So I mean, but it's hard to compare that to your raw presented raw units. Do you know what the within group changes in standardized units, or how does it compare to what you see for a placebo group?
Well, it's about half a standard deviation unit for 1 milligram.
Right.
The 1 milligram group actually consists of a group who actually have a psychedelic experience and people who don't.
Right.
So we can look at that because
in the high dose group.
No, much less in the high dose group, but in the 1 milligram group, it's really 2 groups.
Sure.
So actually, if I gave you the mean, which I just did, it's actually the mean of 2 different groups. And the group who get the placebo experience, the effect size would actually be 1 standard deviation unit because the variance is lower and the change is smaller.
So on the group that it was effective for, what was that in units, in standardized units? Do you know the change?
It's in the 25 milligram group, it's 12 over. It's about 1 standard deviation unit.
It's about the same as placebo.
As a standard deviation unit,
there's
a difference in standard deviation.
Yeah, no, I think one of the criticisms of these studies is that it's very obvious what you're taking.
Yeah, well, take us down that route then. So what are the implications of that? That the study doesn't count?
No, but that there should be some caution applied before you need to compare it to. You have to take into account the placebo control. And I think contextualizing it in that context is really important.
Yeah, but the 10 milligram takes us right. You know, the evidence for efficacy is the dose response. It isn't just a difference from placebo.
Yeah. That's fine. I mean, or the extent to which the side effects could be.
I mean, basically,
I think placebo has a dose response effect as well. So.
Yeah, 10 milligrams and 15. Well, there's only a single administration. I mean, bear in mind that usually placebo is repeated administration of the drug every single day, and it's also measured after a period of time. So I think the comparisons have got to be fair. Okay.
Okay, I think that's all we've got time for tonight.
Okay, great.
Thank you very much.
Not at all.